Take a seat. We'll begin our afternoon session. Hope you all had a good lunch. I'm looking forward to looking around and seeing all of you dozing off after lunch. But we're going to begin our second session talking about early response to the AIDS crisis here in Pennsylvania, beginning with gay physicians who dealt with it early on. And to begin that, I'm going to introduce moderator and my friend, Pesci Zinman. He's the founder of the AIDS Library here in Philadelphia and the president of the LGBT Revolution. Pesci, take it away.
Thank you. Make sure this is on. Okay, so thank you, everybody. I'm going to set the stage for this program. And actually, I'd like to ask both John White and Nick If to come up. So good afternoon. So I'm Pesci Zinman, and as Bob said, I'm the chair of the LGBT Elder Initiative and a longtime AIDS activist. I was a volunteer with Philadelphia Community Health Alternatives starting in 1984. I co-founded the AIDS Library of Philadelphia, Action AIDS, and the Safeguards Gay Men's Health Project, along with John White. And I served as the executive director of the AIDS Information Network from 1989 to 1998. How the world has changed since the beginning of the AIDS epidemic. We have an out lesbian in the Senate. A gay man is the head of one of the largest corporations on earth. And the Pope is backtracking on his meeting with a homophobic county clerk who refuses to issue marriage licenses to same-sex couples. And yes, same-sex marriage is now legal throughout the United States. Today, almost 35 years into the crisis, the work of the past 35 years of building social and medical support structures to deal with the disease and its effects on members of our communities is now being used to support the health and well-being of our entire community, including the health and well-being of LGBT older adults. And how wonderfully ironic that is. So many of us never expected to have survived long enough to need or benefit from such supports. In Philadelphia, those support structures had their beginnings partly at the Gay Community Center. One of those structures was the Philadelphia Community Health Alternatives, an organization that initially conducted STD testing in the bathhouses. To deal with the AIDS crisis, part of PCHA evolved into the Philadelphia AIDS Task Force and part into what today is known as Action AIDS. Today, PCHA is now known as the Mazzoni Center, the premier LGBT health organization in the Philadelphia region. Philadelphia Fight, Galay, Colors, Babashi, Safeguards, AIDS Library, AIDS Law Project, and so many other critical support structures are in place today as a result of the AIDS crisis. It is a testament to all the people who literally dedicated their lives to helping fight AIDS and to care for the people dying because of it. Initially overwhelmed and unresponsive to the pandemic, several of the major teaching hospitals in this city now feature LGBT health programs and attempt to provide culturally competent care. Things are certainly different today, and that is why we need to remember what it was like in the medical community in those early days of the epidemic. We need to know how the social and political environment of sexual orientation and gender identity in the 1980s shaped the response to the epidemic. Those men and women on the front lines of the fight were often closeted or just coming out. They were young, did not have the experience in dealing with a public health crisis, and did not have mentors or elders with relevant experience to call on for advice and counsel. Two of those young medical professionals are here with us today. John White came out and became active in the gay liberation movement during college in the 1970s. He received his MD and PhD degrees from the University of Pennsylvania and became active in the gay and lesbian health movement during medical school and served as co-chair of the American Medical Student Association's Lesbian and Gay People in Medicine. Rumor has it that John was the first openly gay med student at the University of Pennsylvania. He and his partner, Tom Wilson Weinberg, moved to Minneapolis for his residency training in 1981 at the dawn of the AIDS epidemic. Together, they were founders of the Minnesota AIDS Project. In 1984, when they moved to Boston, John became active in HIV prevention efforts with the AIDS Action Committee. In 1989, they moved back to Philadelphia, and John, Anna Forbes, and myself founded the Safeguards Gay Men's Health Project. Since 1992, John has been the director of the Moss Rehabilitation Research Institute, part of the Einstein Healthcare Network. Dr. White is going to tell of his experience and the atmosphere in which he completed his medical education and his early career in medicine as an out gay man. Dr. Nicholas Ift was one of the founders of PCHA and the first board president of the Philadelphia AIDS Task Force. He is a primary care physician who has had his beginnings in community health centers throughout the 80s. When he got involved with PCHA, he was mostly involved in STD screenings. So I'm going to turn it over first to John to tell of his experience, and then to Nick to talk of his experience, and then we're going to open it up to the audience for discussion, and I will moderate. So thank you, Dr. White.
Thank you. Can everybody hear okay? So as Hetty mentioned, I came out in college in around 1972, and I made a decision to be publicly gay at college. And then was in the process of interviewing for medical schools. I wasn't quite brave enough to go into all of my interviews wearing well, there weren't rainbow flags at the time, but whatever. But it was my intention, once somebody gave me a spot in a class, that I would be out. And so I did, I was out from day one in my medical school class at the University of Pennsylvania. And I think it was a bit of an educational experience for my fellow students as well as for my faculty. As she also mentioned, we left town right at the AIDS epidemic was beginning, so really my historical involvement in Philadelphia was with the gay health movement leading up to AIDS. My AIDS-related involvement was primarily in Minneapolis, Boston, and then in my second wave here in Philadelphia. But because I hadn't really come out in a political way, I immediately started thinking about what does it mean to be a gay physician, what does it mean to be a gay patient, how does this relate to my professional realm, and I joined some early gay health-related organizations. And there were gay health-related organizations in the 70s. They were, at least in my experience, there was sort of a tension within them, because there were certain people like me who were relatively out and who wanted to use these organizations as activist organizations to make healthcare better for gay people, to make the working lives of gay health professionals better. But there were still a lot of gay health workers who were deeply in the closet, and they really wanted these organizations as a place to meet other closeted doctors that they could date and be friends with and live happily ever after with. So there was really very often some conflict about whether the mission of these groups was primarily a social mission to support closeted gay professionals who felt alone and oppressed in their work, or whether it was to pave the way for better health care for gay patients, which was more of my interest. A number of organizations related to gay and lesbian health formed not only locally but around the country. So locally there was this Physicians for Human Rights that summarized the dilemma that I just mentioned. Some of us thought, why is it the Physicians for Human Rights? It's really a gay group. Why is it the Physicians for Gay Rights? But of course, human rights was a good thing to call things if you didn't want to be too out in the process. But nationally, there was an organization called Gay People in Medicine, a medical student organization, and soon it became Lesbian and Gay People in Medicine. There were some local organizations for medical students in Philadelphia. And in around 1977, there was launched a national gay health conference. So this was a national meeting that people from all over the country went to who were involved in gay health activism. That started as the National Gay Health Conference, again, National Lesbian and Gay Health Conference shortly thereafter. And then we began to see the organizing of clinics that were intended to serve lesbians and gay men. So the Howard Brown Clinic and ones that started here and elsewhere. Many cities began to develop these kinds of clinics. But before AIDS, the question you might wonder is, what really were the lesbian and gay health issues? I would say that probably an overarching one was really one of access and sensitivity. So whatever your specific health problems were, if you felt like you couldn't be yourself with your doctor, you couldn't acknowledge that you were in a relationship, couldn't talk about your sexuality, couldn't talk about anything really personal, that was a huge problem. And so first and foremost, we were working to make sure there were places for lesbians and gay men to get any manner of healthcare needs addressed while being themselves. And in 1980, the co-chair of Lesbian and Gay People in Medicine with me, it was a committee that had a male and a female co-chair, Lisa Capaldini and I published in the prestigious Delaware Medical Journal Treating the Lesbian or Gay Patient. So it's not a very prestigious medical journal, but it was a publication of a how to take good care of gay people in a mainstream medical journal in 1980. Another thing that we were focused on, of course, was mental health services. We heard a lot this morning about how mental health services were almost inherently damaging to lesbians and gay men at this point in time. And so we were sort of sharing this advocacy around accepting forms of psychotherapy for gay men and lesbians. And indeed, here in Philadelphia, a mental health agency was started called the Ehrman Center. Tom and I were both involved with that. Tony Silvestri, who's here, was involved with that. This was basically a psychotherapy clinic specifically for lesbians and gay men, which was staffed by lesbian and gay psychotherapists, and obviously philosophically was not pathologizing. And then there were some more specific issues that relate more closely to sexuality. So for women, these were primarily gynecological health issues. It began to be clear that lesbians had a somewhat increased risk of breast cancer. There were also concerns about women being sort of pressured to accept contraception, whether they were sexually active with men or not. For men, it was STDs was the big sort of gay-specific issue. And started off with gonorrhea and syphilis, and then we started hearing about drug-resistant strains of those, and then we started hearing about intestinal parasites that were being transmitted through sexual activity, and then we started hearing about hepatitis B, and then we started hearing about hepatitis non-A, non-B. So it's like there was this climate of gay men need to understand their risks of contracting a sexually transmitted disease, but the frame on it was frequent screening, frequent treatment, but no real talk of behavior change or condoms or anything like that. And yet we kept adding to the list of diseases things that were harder to cure and more dangerous as time went on, though not yet HIV. There was a particular publication that was pivotal at this point in time with an obscure title, Morbidity and Mortality Weekly Report. This was a little thin weekly publication by the Centers for Disease Control, and it had a lot of stuff about gay-related STDs because it was a surveillance epidemiologic journal, and there were a lot of pockets of STD in gay communities. So we were getting written about by MMWR on a regular basis, and indeed it was the June 1981 issue of MMWR, which I received in my mailbox in Minneapolis a few weeks after going there, that announced this unusual immune problem that was starting to be seen. So just a couple more things about what was going on in this era. The rise of these STD-oriented services ultimately led to a coalition, the National Coalition of Gay STD Services, which was chaired by Mark Behar since around 1979. Then Walter Lear, who was a gay man who was for a time the director of the Philadelphia Health Department, he and I co-authored a pamphlet called Sexually Transmissible Diseases Information for Gay Men, which was published by the Philadelphia Health Department. I regret to say I don't have the exact year of publication. I think it was in the late 70s. But I know that we revised that publication to add a chapter on AIDS in 1982. So I point this out only to say that the health department was pretty early on in terms of trying to develop some gay-specific resource materials. And then you can see that that very publication sort of morphed from STDs into STDs plus AIDS, which I think is how a lot of the infrastructure for the beginning of the AIDS work came from what was already an infrastructure being built around STDs and so on. So at the end of that, I moved to Minneapolis, as I said, in 1981 to start residency. So I really left Philadelphia before the first cases of AIDS were announced here in the city. I went to Minneapolis in time to see about a year later the first cases emerged there. So I guess what I see is the connection between these kinds of general gay and lesbian health-related organizing in the 70s to a structure and a set of attitudes and a set of professionals who were kind of poised to take on the new challenge of AIDS as it emerged.
Thanks, John.
Slight bit of overlap. Walter Lear called me in the May of 1982, because I was the president of the Gay Physicians Group at the time, and also involved with PCHA, and asked if I would get some people together to start thinking about what we could do about AIDS. At the time, there were 7 cases in the Philadelphia metropolitan area. So we started by meeting with Bob Schrar, who was the head of the Division for Disease Control in the Health Department. He was excellent and very helpful from the very beginning. And we decided that we would need to do a lot of things, not just for the people who were sick, but that people who weren't sick needed to know how to protect themselves, and for the larger community, many of which were starting to panic about the disease because so little was known. So we had to educate ourselves, our peers in the community, and people that were outside the community whose homophobia was on the rise because they were afraid of gays because they thought they were bearing disease that might affect them. I was saying earlier to these guys, the first real AIDS conference that I went to was in New York in early July of that year, and we'd all been waiting for the hepatitis B vaccine, which had been made from the serum of gay men in New York, and it was due to be released at the end of July of '82. Well, at that conference, they announced the first hemophiliac cases of AIDS, and there was no other risk factors. And that meant that it was obvious that confirmed that the virus, well, I didn't say virus, people thought it was a virus, but they called it the AIDS agent, was transmissible in blood. And in this case, what the treatment is for hemophilia is transmission is vials of factor VIII, which is made from blood, and the reaction in the room, where there were a lot of infectious disease people, was to say, well, we'll cancel our orders for the hepatitis B vaccine because they were planning to vaccinate everybody in their hospitals. Now the vaccine was tainted by AIDS because it came from gay men in a high-risk city. So that didn't happen. The vaccine never was released. A new synthetic vaccine came along a few years later. And also at that meeting, Jim Curran from the CDC was sort of starting their group within for AIDS, called several of us aside and said, you need to start thinking about blood transfusions and the blood supply, because this is going to come up from the larger communities. And the first thing I'm going to do is try to ban gays from giving blood. And he said, CDC was calling a major meeting of blood banks and things to later in the summer to get to a policy. And what we came up with, by talking with our community and blood networks, was that they could screen by asking people who, if you were gay and had multiple partners in the last 6 months to a year. The political side of it was they shouldn't categorically reject gay blood. So here, the local Red Cross sort of didn't get the memo, and they announced that they were going to ban all gay men from donating. So we were sort of like less than a month old. I had to take on the Red Cross by saying, they've got it wrong. Ultimately, we set up a meeting with them, and they, changed their minds on it. So that was good. in the beginning of August of that year, I went to one of those gay health conferences, which was in Dallas that year, and met a lot of people. Also, Jim Curran was there and asked the group that was working on AIDS what we would like it called, because there were all these names like gay-related immune deficiency and gay, every one of them were gay something. And so we voted for AIDS, and that's how AIDS got its name, with a small group of gay people. And here we talked about things that we needed to do. We needed to gather information as much as we could get, and keep gathering it as time went on, to pass on to our community, and to develop a hotline for our community to be able to ask questions. And we had one through the Gay Doctors Group that was up and running. We just expanded that a little bit so it had more time and trained more volunteers. So that involved an education community and a hotline community. And while I was at that meeting in Dallas, I met a guy who I knew vaguely here in Philadelphia, Larry Gross, who was professor of communications at Penn. And he was talking to the group about how you reach the gay male community, since they're not all in Center City in Philadelphia. They're everywhere. And he said, so you need to take advantage of any chance you get to be on radio or television or in the newspapers, because that's the only way you're going to get to them all. So we did that. Anytime somebody would call up for an interview or something, we'd send somebody to be there and get the message out. And it was difficult because they didn't want to say things like sex on television, for instance. They didn't want to say things like condom. They thought that was like too much to bear for their audience. So eventually they got around to saying it, but it was somewhat of a struggle. And Larry also was in the process of developing literature for our community, and he suggested that one of the things that would be very helpful is if you made the literature very small pamphlet that would be no larger than a credit card. It could be folded over, but all in all, it should be no larger than a credit card. So we went back to designing our thing and cut it down to the bare minimum of what we needed to say. And that was putting a hotline number on there, basic information, and we referred them to where they could get more information in a larger pamphlet that we had. And that was available at the task force. We didn't have an office at the time, or a couple of other places in town, including Giovanni's room and another popular gift store and card shop in Center City. And in the beginning of '83, we started putting these posters in subways and buses. Now, the first thing, you see, the message is always the same, but the one is crossed out. At the time we made these, it was really only one new case a week. we kept this poster going for years, and would then put the new number of cases. And the reason there are some 5s and 3s there is that when I got these, I only had 5s and 3s. So it's saying nothing about the prevalence of the disease in those communities. And from the beginning, we did have the 4th of those, I didn't find the 4th either, but there's a mock-up. We had our 4th one, which was directed for IV drug users, and telling them not to share needles, because that was another big group. And actually, they seem to have gotten the message better than a lot of young gay men. I see a lot of IV drug users or past IV drug users in my office now, but most of them stopped using drugs back in the 90s, which is when they were infected. And they, or they started getting clean needles.
Thanks. Dr. Rift, I want to ask you a question. So I've read about when you had an interview at KYW, and you thought that interview was going to be a radio interview, and it turned out to be a TV interview. And when I read that, I kind of thought of John Fryer going before the APA in a mask and wig and talking about being gay and being a psychiatrist. Could you tell us about what that experience was like for you as a out or closeted physician?
Well, the physician part of me wanted to stay closeted. And Brett Cassins, who was also with us on this, called me, and I was actually homesick with the flu, and wanted to have me come along with them for this interview with KYW, and he thought it was radio too. So we went over, it was going to be in his office. We went over, and it was the TV thing on it. We're both, this is not being good. It turned out that it was actually okay. More trouble came later on. An Inquirer reporter called Don Drake did a wonderful job of covering the AIDS epidemic in Philadelphia and in New York. And he called me, there was a series in the Inquirer for about 6 months, and he called me one day and he said that he was ready to talk about the AIDS task force in his series, and did he say I was gay? And I said, I would prefer you didn't. He said, why? And I said, jobs and things like that. And so he said, okay. When the thing came out, the section on the AIDS task force, and he had come to some of our meetings, was 16 gay men meeting in the Center City apartment of Dr. Nick Gift. So, well, what's this straight man having 16 gay men in this? So there you are, out, totally out.
So this is for both you and John. What was it like dealing with colleagues around AIDS? I mean, were they afraid that you had AIDS because you were working in the field of HIV/AIDS? How did they react to you as being gay? Can you tell us about that? John?
Well, as I mentioned, I was known by my colleagues to be gay quite a bit before the AIDS epidemic. There was definitely homophobia in medical school. Most of it took the form of people people trying to give me advice about how not to get myself in trouble. You know, you might have trouble if you do this, you might have trouble if you do that. And when I went to start my residency in Minnesota, they had a little photo book of all the incoming residents that gave little bios, and I submitted bio material that said that I was gay, that I had a partner, that I was involved in the gay liberation movement, whatever. And my chairman pulled me aside and he said, you know, I think this might make your life difficult. Maybe you want to rethink the content for this bio. And I said, you know, I think I have quite a bit more experience in the realm of coming out than you do, and I think it'll be okay. And it was. I mean, what I discovered really was that because I was in these situations where I had repeated contact with a fellow student, a fellow physician, whatever, they got over it. I mean, they might be freaked out, and then they would get to know me, and they would get over it. And I think it had that's what coming out politically is about, is exposing people to this scary thing that they don't know anything about. And mostly that worked out okay for me. When AIDS came along, I don't remember people perceiving that I might have it. I mean, one of the sort of naivetes was I was a happily coupled person, so of course I couldn't have AIDS. They probably thought of me as safe because I was in a relationship and so on. So, but they were certainly scared of patients and other people, and so was I. I mean, in the beginning of the AIDS epidemic in Minneapolis, I remember gowning and gloving to go into a patient's room that I was visiting and setting a pen down and then wondering, should I throw away the pen because I don't know what's on it, and can I write with it anymore? You know, it was a very scary time.
Dr. Ed? Actually, I didn't have much problem with colleagues. And some of the things that meeting with people from other cities that was surprising, like the people from GMHC in New York said, what are you guys doing about visitation rights in the hospital? And I said, you know, that has been solved in Philadelphia a long time ago. And all the hospitals, but you know, the partners of patients come in, you know, like anybody else. So it really never came up in relation to AIDS. There was a problem with nursing personnel in one hospital here in Center City, and they threatened to not see a patient who had AIDS, a couple of them, and the nursing supervisor, this was at night, came and told them that was okay, but they would have to have their reservations on her desk by the end of the shift, and that was it.
Interesting.
And that kind of thing happened occasionally in more out-of-the-way hospitals out in the suburbs and things like that.
So, do you remember your personal emotions as physicians being trained to help cure people and not being able to cure people? What that was like?
Well, I mean, my field is rehabilitation medicine, so I don't cure anybody. I treat people who have disabilities and chronic diseases that they're not going to get over, and that I'm going to help them lead the best life they can. And so in that sense, I suppose it's not that big a difference. I think the thing that was horrible was seeing so many people that I knew personally die one after another. I didn't expect it. But you know, people in my era, we just lost tons of friends all at once. Tons of friends.
Dr. Rick?
Well, kind of my field is kind of like drugs in the sense that if you're doing primary care, you see patients over a long time. So you're not going to cure most of the things you're treating as patients go on with their lives. You treat them for things, but you're not going to get, they're not going to get better over most of them. So that didn't bother me, but the rapidity with which the disease would destroy people. The first time that a patient came in, I'd seen him just a few weeks before, and he was skeletal. That upset me a lot.
Yeah, I think people today don't envision how rapid it could be. I mean, I remember when we moved away from Minneapolis to Boston, I had become friends with a young lawyer who had recently moved to Minneapolis, who was perfectly healthy and vigorous, and of course we talked about AIDS, but not in personal terms. And within a couple months of me getting to Boston, I got a call from his doctor that he had died. From diagnosis to death in weeks.
So what kept you going in the darkest years before the first therapies were discovered and made available?
Well, I would, patients already knew that there was no cure for it during those darkest years. So I would say, well, we know what the statistics are. For instance, that was plotted fairly early that the death rate came to be 50% at 10 years. And I said, well, our job then is to make sure that you're in the other 50%. And that you stay alive until we get better treatments. And kept, that thought in mind for the patients, to keep that thought in mind. And it worked for some of them. I don't think it was anything I did. They just, were lucky ones. And I still see some of those patients like 30 years later.
I guess for me, this was so deeply embedded in my gay political consciousness. This will sound harsh to say, but I wasn't so much focused on the people who were dying because, as Nick says, we knew that we didn't have much to offer them. I was focused more on preservation of a gay community. What is it? How do we live our lives in this climate of risk? What does it mean to have an identity that's defined by your sexuality if you're scared of your sexuality every day that it might kill you? I mean, these are really challenging things to think about at the level of community. So my investment was in prevention because I thought that I can save the people or try to save the people who are not yet infected. And it was on finding a mode of prevention that is not homophobic in its essence, i.e. a way to be a sexual being, a gay person, and still live a healthy life. Because of course a lot of, especially the early talk about it, just kind of intertwine homosexuality itself with the risk, and so the only way you could kind of avoid the risk was to stop being gay. And early prevention workers were trying to find, obviously, a more gay positive way of speaking about that.
Folks, open it up to discussion, questions? Yes.
Well, I would like to interject if it's appropriate that we need to confirm here from the patient perspective, the man on the street perspective. I contracted HIV sometime before 85. I don't know what it was. My partner did as well. We didn't get tested until 87. It was until AZT became available. It really wasn't much reason to get tested because there wasn't anything to be done. We got tested. He at that point when he had AIDS. AZT was available, and we still got it. Basically kept him alive for 2 years, and then he died. I obviously am still here. And because during those years, when there was nothing, when I was an avid reader, when I was New York Native, which had an awful lot of information in it, against health crisis treatment issues when that became available. I was aware of sort of what, generally speaking, was going on with why I was thinking as a doctor. And I made the decision when I tested positive and when I got my T-cell counts, which were just below 400, I said, this ACT is clearly very toxic, and that was clear sort of pretty much from the start. And I said, I'm not doing anything. As long as my numbers are constant and I'm feeling okay, I'm not taking anything. I've been on a very, very heavy vitamin regimen since the early 70s. It was a very weird incident in my life, but it sold me on Adele Davis, and I was on really a very heavy vitamin regimen since then. And I really didn't do anything until 99 when I got my first viral load back, and it was high, and so I started taking meds. But even then, because I was a good medical consumer, I knew what I didn't want to take. And I knew what I did want to take, and I searched around. I inquired various different doctors, and luckily I was living in Chicago at the time, and the doctor's office that I went to had a relationship with West Presbyterian, which is where Howard Kessler was. And so I got a consult with his office, and without my saying anything, the doctor there, after hearing my history, prescribed exactly the regimen that I wanted, which had not been AZT. Knock on wood, I've basically been on that regimen ever since. But there was so much that the fact that there was nothing out there as far as one knew. The fact that what was out there was extremely toxic and supposedly only had a very short time when it was going to be good. I mean, I thought it was weird that the doctor, when my partner started taking ACT, said, as far as we know, this is good for about 2 years. And some weird, it actually happened 2 years later. That's when sort of he started to fail. It was fine for 2 years. But somehow or other, from all the stuff that I read, I knew in my gut that although obviously tons of people had died and died quickly, it was not an automatic death sentence. There were people who did not die quickly. And I've been living a lifestyle in a number of ways, very much like a typical gay person, in a number of ways not involved. Sexually, I was very unfortunate. And the medical profession always being focused really on medicines as opposed to more homeopathic things, vitamins, and those kinds of things. We're skeptical about that. Never sort of looked at that, but I'm convinced that one of the reasons why I'm here now is because I was on a very healthy dose of vitamins since the early 70s, and that put my immune system in such shape that I was able to deal with this for many years without taking any medications. And when I finally did, it was something relatively low key in terms of its toxicities, and I've been able to stay with that since. But it was a terrible time for people on the street because you just had no one knew what was happening, and it was just very. And most people do not read a lot, so for them it's scary. I had knowledge.
I mean, there was, just to remark on one aspect of what you're saying, there was interest early on in this phenomenon of people who don't get sick, who are known to be HIV positive and don't get sick. The problem is, I don't think, well, in more recent years there have been some genetic things that have been identified for occasional people, but I think the problem is that everyone had hypotheses about why some people lived. They're no easier to study than any of the drugs. In other words, you'd have to get thousands of people who take lots of vitamins and compare them to thousands of people who don't. And so you can imagine in this climate, there were all kinds of desperate searches for things other than meds that would help people live a long time. And I think it was not easy to find solid evidence for any of those things because they would each take the same kind of study that the drugs that we have would take. And I agree that drug companies are more interested in doing those studies on drugs than on things that are not patented or patentable, but they're no easier to nail down.
Right.
I understand.
I mean, there are long-term non-progressors. People who were infected at a certain point, their viral loads were here, their T cells were here, and then it just took them much longer to progress to a point where they had to start antiretroviral therapy. But I think, whatever worked, whether it's vitamins or prayer or therapy, glad that you're here to share that story. Randy.
Just a question, something that's I've always found curious, was the gay community's embrace of medicine and like actual search in the early 80s if you know the whole history, and I was always very fascinated with history, and the treatment of the medical community of gay people, the earlier stuff we're talking about up through the 70s, and the psychological treatments, and you can go on, lobotomies. I've always had this healthy skepticism of stay away from doctors and stay away from medicine, and I still won't take medications and don't trust drug companies or anyone. And at the time, there was this real embrace by some people. I was watching people put almost anything in their mouth. I understand, I was one of the people I was afraid I was going to die. Everyone was afraid you were going to die. But watching this almost overnight switch of fear of the medicine to embracing it, I never quite understood. And I always wondered if people didn't know the history, because we're not taught that history, right?
I mean, maybe this is simplistic, but I think I see that phenomenon anytime somebody is at risk of death. That is, not to denigrate any religions, but I know of Christian scientists who are Christian scientists until it's death's door, and then they want a surgical operation or whatever. So I think that our culture teaches us, rightly or wrongly, that drugs are magic bullets, and you cannot believe it until you desperately need a magic bullet, and then you'll say, I wonder if that magic bullet might be magic after all.
And also I want to say that how people died from full-blown AIDS was just terrible. And I remember visiting a friend of mine. He had been diagnosed and then died. And when I went to visit him in the hospital, he was so deformed and so sick and in such agony that I thought to myself, anything is better than this. If it's me, I do not want to die an agonizing death. And so I will hold out my hand to anything that might prevent that from happening. And so I think that is a lot of why our community embraced medicine and the hope of a cure, the hope of...
There was a time, you remember, people were fighting to get into clinical trials. I mean, there weren't many clinical trials, and you wanted to get in them, and people would get all the pills from clinical trials. I mean, there's supposed to be whether they should be blinded or not, I mean,
Sure.
like the placebo or not. And so people would get the pills, and everyone would band together, and then you would shake them all up and pass them out. So you think you'd get at least half real medication. And so people were like, then you could take the drugs to a chemist and find out if they were real or not. There was all this gaming of the medical system that a few years earlier, we tried to give you a pill to cure your homosexuality, and now you were just
clinging to life.
Yeah, but I think you raise an interesting issue, but I think there are a bunch of prongs to it. That is, first of all, there were people who were rejecting it. There were people who rejected the notion that it was an infectious agent and thought it had to do with unhealthy living in a more general way, and therefore, obviously, the solution would not be an antiretroviral pill. It would be improve your diet, reduce your stress, whatever your take on it was. The other thing is, I think that the way in which gay people jumped on the drug bandwagon was a new and different way. It's not, give me whatever you think you recommend. It was, I want to be in on the decision, I want to review the research, I want to be in charge of when things are FDA approved. So I think it was taking a different level of ownership and a skeptical, collaborative ownership rather than just bring it on medical profession. But I also think, I sort of said this, that when you have seen practically everybody you know die, it's not that easy to say, oh, I don't think I want to mess with those drugs that are made by some nasty corporation. I mean,
I get that, I'll shut up about this, but it's in other communities, like, you'll hear about Tuskegee and the African American, like, there's a real knowledge that's passed down in families and stuff that I don't think the gay community had. I don't think there was this history or sense of history that may have been good or bad, I don't know. But
well, the white educated gay community didn't have that history.
Right, there's probably 20 million Tuskegees you can cite, but no one knew any of them. It just wasn't.
There was also, when ACT first came out, a fairly large number of people who would say, I'm never going to take ACT, and you'd say, why? And they would say, well, I had a friend who took ACT and he immediately started to lose weight and get AIDS, and then he died. They didn't really know whether he had AIDS, but they thought that he had AIDS. And they thought that the medication was making him sick. And maybe it was, but they went from the idea that taking the medicine, the person got sick and died, that the medication was making them sick and causing them to die.
So I want to thank Tom. One last question, and then we have to wrap up.
Okay. Well, I just wanted to make the observation that to some degree with an illness that's so new and so unusual and so strange, there's an organic quality to how patients relate to or don't the medical profession. So a lot of people started by presenting to dermatologists because they saw
Lesions.
lesions and they thought, I have a skin problem. And then dermatologists seem to be on the front lines of further treatments. I was always curious to know, if either of you could answer this, but how did that move away from the specialty of dermatology?
Well, one thing is it got complicated. I mean, I used to give people advice on treatment for AIDS. I couldn't begin to do that anymore with the number of medications and the number of tests and sensitivities and stuff. In the early days, any doctor who was willing to read anything was an expert because there was one drug or no drugs and so on. So I think that dermatologists, you're right, they started seeing cases because of KS, and they knew as much as anybody else about how to handle the disease. So it's kind of through experience that they became experts.
Well, one thing, we're not seeing as much Kaposi sarcoma anymore. And if you see somebody with Kaposi's, if you put them on a good 3-drug regimen, more often than not, the Kaposi's will go away without any specific Kaposi's treatment. So that's how it's gotten away from dermatology.
Okay, thank you again, everyone, and let's hear it for